Okay. Hi, I'm Dr. Manjula Jegasothy. As I said before, I'm a solo cosmetic dermatologist in Miami, Florida, in the urban part of the financial district, and so I have a fairly large cosmetic practice. It's about 85% cosmetic and about 15% medical derm. And I was saying how my father was an academic dermatologist in the 80s, and so he was friends with Eugene Van Scott and all the people who started Neostrata, and so I had access to chemical peels since I was about 12 or 13, playing with them in my bathroom at my house, and I've been doing chemical peels on myself, so I know what darker skin can and cannot do. And I always tell people, if you're going to burn anybody with a chemical peel, it's best to burn yourself, and then you figure out how to fix it too, so that's good. And I think chemical peels are a great introductory way to take a medical dermatology practice into a cosmetic dermatology practice, because you see patients with acne and with rosacea, or you see patients who need skin checks and then also have photo damage, and you can do chemical peels on all of them. And then sort of I call that the gateway procedure, and gets them then interested in feature enhancement with fillers or wrinkle reduction with Botox. So anyway, there's a lot of slides for this talk. I don't have any disclosures with relation to this talk, but I know we want to get to the demo, so I'm going to go rather quickly through the slides. As I said, I personally have had peels for a long time. Human beings have had peels for an even longer time, and they've used all kinds of different products all over the world for it. I think the big, surge in it was certainly with the Baker-Gordon phenol peel in the 1950s, as you know, which was fraught with some sort of cardiovascular complications and stuff, and has fallen out of favor. TCA was still relatively popular even when I was a resident in the 1990s, but I think we've been going more towards peels with less recovery time. Patients seem to find those more acceptable and are more willing to do more peels more frequently to get the results they want without having a lot of recovery. So now we're sort of more interested in glycolic acid, mandelic acid, resorcinol, salicylic acid, etc. So this is what I was referring to with Dr. Van Scott and Dr. Yu. They were the ones who started Neostrata, and they did the landmark publications back in the 70s showing how glycolic acid can basically make the stratum corneum and the epidermis much more even and regulated. Now you see currently, Botox is still the #1 cosmetic procedure, but then after that is fillers and then chemical peels has grown quite a bit. We were seeing, the numbers aren't here right now, but the fillers, peels have actually gone up into the million range, particularly with the recession of the last 2 years. So definitely more people are doing peels, perhaps because the other things are pricier and they can't afford them. But it's still a very, very good procedure, and it's great for all kinds of problems, including photo damage, superficial wrinkles, things like that. That's an actual peel mask, I think. So, as I said, it sort of takes away the upper layer of stratum corneum, which helps everybody. I tell patients that as you are aging, you don't really self-exfoliate the stratum corneum as well as a teenager does, and so therefore your complexion becomes dull. That also then causes stratum corneum to deposit into the fine lines. It causes your seborrheic keratoses or actinic keratoses to become more rough and uneven, and then also it clogs pores in acne-prone and rosacea patients. So the whole thing of non-sloughing of the stratum corneum is really the primary issue, and that's the first thing that peels address. So any peel can really help almost anyone. And, I think even from age 25 on, and certainly younger if they have acne. So these are we were talking about some of the different chemical peel agents, and that's a whole list of them. The Neostrata products we're going to use are primarily glycolic acid, and then they have some boosters that have some mandelic acid and citric acid also. As I was saying, I think we're sort of the very superficial peels are more popular nowadays because patients have a lot of social activities and don't want much downtime, and they're actually willing to come more often as long as you set the expectations right to get the results over time, rather than getting one big peel that takes off all their skin and they have 2 weeks there where they have to stay at home and they get the same results. And then we were talking about the depth of peeling, and I think you guys all know sort of which goes how deep, and right now we're going to do superficial peels in this particular symposium. And then, obviously, as I said, it's kind of a gateway, so a lot of people who start with chemical peels and are happy with their results will then go on to doing other things. They'll go on to doing neurotoxins and fillers and laser, et cetera. Again, I think the stratum corneum issue is the thing that then ends up causing all these other problems, fine lines, coarse lines, pigmentary issues, which are slightly separate but can be improved depending on what you use on them. Kojic acid, well, I'll show you some boosters we're going to do that have kojic acid in it that can help brown spots. So these are the most popular, what we call lunchtime peels. It's a kind of a marketing term, but definitely when you do superficial peels on patients, as long as it's not their first time, I generally can do it where they go back to work afterward. I prefer if they don't apply makeup right away. I say let your skin breathe a little bit after you did the peel for an hour or two, but certainly, you know, at the end of the day, they take off their makeup, they come get the peel, and they could even go out that night or anything like that. And those are the kinds of peels that are most popular in my office. So salicylic acid, the main thing to say about salicylic acid is that you do have to be careful with it a little bit in darker skin types, but it is something you can use. One thing about it is that when it gets to the deep epidermis, it does kind of get somewhat neutralized, so you don't have to worry too much about it going very deep, even if it's accidentally left on too long. The thing I like best about salicylic acid is that it basically is good for oily skin, and it goes into the pore, so I like it for acne and for extractions and things like that, probably the best. So then again, there's Jesner Solutions, which has lots of different components to it. I don't do Jesner's a whole lot just because patients don't like the downtime that much. And then TCA, you guys know. And then there's combination peels with TCA and glycolic, et cetera. Those have some more downtime. They're for sort of more mature skin types who don't mind that kind of recovery. So I use glycolic acid peels. These are the ones we're going to be doing here today. Again, it's the most studied, has the most proven track record. It also is really good for exfoliating the stratum corneum, so that has a wide range of effects because of that. It's a very simple acid, sugar-derived acid, and so, you know, I think it's even safe, really, in pregnancy, et cetera. I do a lot of these peels, and it's the only thing pregnant women can do to help their skin if they're acne-prone and such. So it's another nice revenue stream for that. This was actually the slides with all the numbers. I don't know why they put it here. Am I going backward? No. Okay, I thought I saw that one before. All right, so the main thing I think when you get to, when you use peels from different companies is that you want to use a reputable company's peels simply because you can be guaranteed, it's like using a branded pharmaceutical, you can be guaranteed about the composition of the product. You know, different companies advertise their peels 20% glycolic, 30% glycolic, but the important thing is the free acid, okay? So the free acid is what actually goes and sloughs off the stratum corneum. So the percent of free acid can be guaranteed to be the same in every single 20% from a certain company that's reputable, then you know you're going to get, you know, the same results every time. And you know, there won't be any unpredictability. So especially when you're first starting, I think that's very, very important. So you can see here, for example, there's a 50% glycolic versus a 20% glycolic, and when the free acid levels are different, it makes the pH very different. And so the ones with a much more physiologic pH, because a lot of that acid is not free, you see is a lot less of an insult to the skin than something that's a very low percent glycolic acid but has a lot of free acid, making the pH very low. So it's important to know how much free acid you're getting, and so therefore in companies with good reputable glycolic acid peels, you'll know that. You know, you can reliably say it's this pH, etc. You see, it's not going forward. I don't know. It's staying on the slide, and it's doing that on the computer too. The black button? Okay. Here. That's okay. I mean, I don't mind doing the peels. Okay.
So which one?
No, that's fine.
This one, right or left?
It's that. It's the right.
Right there. Is that where you want to be?
No, we were there already.
Perfect. Excellent.
Okay. Glycolic acid peels can be used on everyone. I probably wouldn't go with Fitzpatrick type 6s. I think there's other things that you can do on Fitzpatrick type 6 skin that is that's effective without having to worry about the timing so much. But certainly Fitzpatrick 5 and lighter, I think glycolic acids are great. Again, you can do it on all ages. Like I said, even when they're 25 or older, they still have some degree of non-exfoliation or some clogging or something that it can be useful for. Again, the hand, lots of different areas. I do a lot of peels on the back and a lot of peels on the chest for acne. The extremities, it depends. If they have a lot of keratoses, sometimes it helps. I'll combine it with liquid nitrogen or C&Ds to do for keratoses or lentigos and other things, and that can be helpful too. And then, as we discussed already, multiple skin conditions such as acne, rosacea, scars. Obviously everyone's talking about Fraxel laser for scars, but I think chemical peels also do help superficial pitted scars to some degree. If they're done, if the patient's expectations are managed and they're done over the course of time, they can help. And there are patients who can definitely afford $90 for a chemical peel, but they can't afford $500 or $750 for a Fraxel treatment, and so this is certainly an option that they can do that will improve their skin over time. Melasma, I think melasma chemical peels are still the only and best thing to do for melasma. A lot of, every laser company comes out with, we have laser now for melasma, and I think we experience this, sort of phenomenon where people are using every new laser for melasma, and then a year later there's a rebound with it in most of these patients where they're even worse than before. So I really don't offer melasma patients anything except time for their hormones, their estrogen levels to sort of slowly decline. Hydroquinone, Kojic Acid, arbutin, bleaching agents, and then superficial chemical peels. I like resorcinol, I like mandelic acid, to some degree, I like glycolic acid, and I like pyruvic acid. So those are the ones I use for melasma. And then obviously post-inflammatory pigmentation, I think it's great for, and I think it's probably the best thing for it. For post-inflammatory pigmentation, I also obviously use some cortisone gels. That always helps. A lot of this also is excoriation and picking. So if they can do a barrier cordran tape or something at night and then do a cortisone and then a hydroquinone, or depending what they'll tolerate. Some darker skin types can't tolerate a hydroquinone, so you can do a Kojic acid or arbutin or something like that. And then obviously glycolic peels, and then all the other ones I described for melasma. So these are all there's a lot of studies on photoaging. And if you guys read, you'll see all of these. So these are elastin stains. You can see before and after really does improve collagen production too. So it does have effects that are even deeper than the epidermis. And again, this is photoage skin. You can see the elasticity is better. So Dr. Dietry's pictures. Same thing, actinic keratoses. And so she's someone, you would use multiple modalities on. You would do liquid nitrogen perhaps on her brown spots, or you could do, bleaching agents, and then some people would do a resurfacing laser. Again, so for some of those lines, we might do filler, et cetera. And then, but I think everyone can benefit from chemical peels. Now these case studies show where they're only using chemical peels and they're getting this much benefit, so. Same thing. And we just talked about how it can be combined with lots of other procedures. I like it as a gateway. So what would we recommend? Now this is when we have more time and it's a lecture without, so we're going to go through that. So this is kind of what they're sort of saying that Dr. Bryden would do. Again, you can see before and after with Botox filler and chemical peels. And then the prep, you'll see all this when I'm going to do the thing. It's good to use a pre-peel prep simply because even when patients wash their face, they could leave some remnants of debris or makeup on their face. So it's good to have everything sort of evenly exfoliated so that you're working from a clean playing field. And then these are more combination treatments. And then the glycolic acid peels. And like I said, this is someone, once you've got them in there, they're cost effective, they like to do them all, for a long time. And then this is all the actual products, and you're going to be able to see them better on camera. This is more sort of Q&A on what you would do. See, she's just had 6 glycolic peels, and she's gotten so much better with her melasma. So if you actually added some other ingredients as well into the glycolic peels, they do very well. They have to be managed, though, to make sure they know they have to keep coming back because it's their estrogen that's making their melasma occur. So once you stop the treatments, it's going to recur, so they have to keep doing them. Okay? And then glycolic acid's safe, non-toxic, good for lots of things. And now we're going to do the procedure. Ready? Okay. So have you ever had a chemical peel before? No. Okay, so when you start with somebody and they've never had one before, you want to start definitely at a 20% or lighter. And glycolic acid, perhaps more than a lot of the other acids, is very time dependent in terms of the application. So again, with somebody who's never had experience with it, and you want to use a light peel, and you also want to put it on for a very short period of time. Okay, so we're going to do the pre-peel neutralizer. Again, I've had her wash her face before the seminar, but you want to basically make sure that you put this neutralizer on, so the pre-peel cleanser, so that all of the excess debris, excess makeup she might have, anything is all evened out, and you're playing from an even playing field. Okay? So, and you're going to just tilt you're going to look in the camera still, and you're going to just tilt that back. And I just always apply in upward strokes. You don't want to help gravity. And even though she rinsed, I'm getting some debris on the gauze, so there was definitely some makeup left. Okay? And it takes off any sort of loose stratum corneum and anything else that might be there. I'm going to come on the other side. Some people like to work with the patient turning their face back and forth. I would prefer to be on each side. And then my nurse is often on the other side. Then the other thing we like to do is, obviously, the whole thing about if they have HSV-1, I don't do any chemical peels if somebody has an active cold sore. But, they might have excoriated pimples. So they would have some open skin. Now, some of the manufacturers actually recommend that you put on some petrolatum or Vaseline on patients who have any open skin at the time. If you're trying to treat acne with your chemical peel, that becomes a little difficult. What you can do is not put the petrolatum on, but perhaps just put the product, the peel product around the comedone, and then try to extract with that not going into the open lesion. I think with excoriated pimples, you're trying to treat them, so it's okay to get a little bit of acid into them. But certainly for the oral commissures, the vermilion border, the eyes, sensitive areas in the nasal creases, it's good to put a little petrolatum in so that the peel doesn't get into it. The other thing is, you have them remove their contact lenses so that nothing gets burned. And, when you're first doing it, you don't want to look like an amateur, so you don't want them to, you don't want to try to drip onto their clothing. You want to have it, have them covered up so that, because when glycolic acid or any of them these things get onto black clothing, I find it bleaches them. So then you've ruined their favorite shirt, and it's kind of lame. So I'm just putting a little into her commissures, and then I'm using a different tip for the corners of her mouth. Are you sensitive in the corners of your nose? Do you tend to be? You ever get redness or anything?
No. When it changes the mic, it's pointed off in the wrong direction.
Okay.
Fix this.
So a little bit on her vermilion border too. Now, you know, a lot of people have those smoker's lines on the corner, on their lips. So if you're trying to use the peel to treat that, then you might not want to put as much petrolatum on that. And certainly if they don't have any history of HSV, it's not that big an issue. The big thing is you don't want to get any of the acid onto their lips or inside their mouth. Some people sit there with their mouth open, and that's happened, and that burns, and you also look like an amateur, so try and avoid that as well. All right? Okay, so this is at 20%. And again, we're going to time it, right? So as soon as I start, what we try to do is we try to apply the product sort of within 30 seconds or so, again in upward strokes. Try not to get too much on the brush so that they're dripping down again. You try and do it in even upward strokes. And I'm having it timed so that we're going to leave it on. We're going to see, you know, again, a lot of this is sort of feel, and if the patient is, you know, burning to the degree where they're a 5 out of 10 or more, I sort of am quicker to neutralize it than if they're feeling fine. So how's it feeling so far?
Fine.
Yeah? Good. So we're just putting it on. You know, and in this conference, I'm not being aggressive. I'm not going to really go onto her, you know, onto her upper eyelid, but you certainly can. You okay? Okay. And certainly I like to go down, I like to feather down onto the neck and stuff. I think there is a tightening effect, as you saw by the elastin, increased elastin levels on the dermis. So I kind of avoid the creases on the nose. Now you told me you had some clogged pores. Where do you tend to have them?
On my...
on your nose?
Nose, yes.
Okay, so I'm going to actually show you, you guys how I extract also. And sometimes I like to extract, I told you, a lot with salicylic acid, but it can be done with glycolic acid too. How much time do you have?
1 minute and 17 seconds.
Okay, so we're at 1 minute 17 seconds. She's not turning red, as you can see, so she's doing just fine. How are you feeling? How's your pain level?
Great.
Is it stinging or burning or anything anywhere?
It just stings a little, but not.
A lot of people say to you that they don't feel any stinging or burning. They just feel a sort of a mildly itchy sensation, and that's normal too. So what I do for extraction, just going to turn a little bit just like that, is you never use your fingernails. You always use through the glove the pad of your fingertip. And, you know, comedone extractors are nice, but they also mark up the patients. Even light-skinned patients get red for a day or two, and darker-skinned people can have marks from the comedone extractor for, you know, 4 or 5 days. So I try to actually see what I can get by just doing this. See this light squeeze, and that gets a lot of the clogged pores. It actually gets the stuff out. And while you may not get 100% of it out, you can get some of it out. I don't know if you guys can see on the camera. And then I'm going to do a little bit on the sides here. Now, I know that's hurting you a little. I'm sorry. It's a good pain, right?
Yeah.
So, yes, I can see them. I don't know if you guys can. Can you see the comedones? Can you see them coming? So I'm just pushing with the tips of my fingers. And this is the best time to extract. If you have estheticians, you need to teach them this. This is great non-PIPA-inducing extraction. Okay, and I'm going to do the other side the same way. What time are you at?
3 minutes.
Okay, so we got about 2 minutes left. Are you burning or hurting anywhere? And it's good to ask them throughout the procedure, you know, and engage them and tell them, you know, have them tell you how they're feeling. How are you feeling?
It's fine. It's getting less.
It's diminishing, okay.
Yes.
So sometimes, you know, again, when you're feeling more aggressive, you could actually, I like to change my gloves after I extract, so I'm going to do that. So, you know, if they're feeling fine, you can put on another coat if you'd like. You know, go by how they feel. I'm going to actually put on another coat. Let's put on a little bit, just for a second. 30 seconds. Thank you. I'm going to focus it on sort of the wrinkle areas. We'll see if we can get a little bit better around the crow's feet. You okay? Now, she had two places that she told me she was concerned for, this brown spot here and a brown spot underneath her right eye there. So I'm going to use the booster, the brightening booster that Neostrata has, which is, this one. It has Kojic Acid, arbutin, and 30% citric acid. And it's a nice thing, you can just put it on these specific areas, or you can do it on the whole face, depending if they're photo damaged everywhere. And what I like to do is I'll apply this on these places, or everywhere, like I said, and let that dry. Sorry, was I covering the camera? So basically, it's not rocket science. I'm just putting a little bit of this on there, and anything I see that's brown. What time do you have? Okay, so I'm ready to take off. So that's just to demonstrate to you how you can layer things and that sort of thing. And what I like to do also with these different acids for brown spots is I use a plain gauze, and I'll gauze abrade it. See if I can get some of the top layers of the melanocytes, the overactive melanocytes, to calm down or go away. And again, this works, I think, very nicely with salicylic acid and pyruvic acid. Okay, so now I'm going to neutralize. Perfect. So with this neutralization, you want to do the first pass where you can see the nice, can you see the bubbling up? Carbon dioxide, the peel acid is reacting with the neutralizing, the bicarbonate in the neutralizing solution and creating this sort of bubbling effect, so you know that you're neutralizing properly and effectively, so that the patient doesn't walk home or go home with any peel left on their face. How's that feel? Good?
Great, yep.
It's soothing too. They tend to like it. So it's probably better to apply this, you can see, as a spray, even though it might be a little bit messier, just because you can see that nice bubbling effect. See that? So you know you're getting all these areas nicely neutralized. Very important to get the nose, because that's where things tend to go in and settle. Okay, I'm going to get you spray your nose. Just don't breathe in. Good. It's okay to get a little bicarb on their lip. That won't affect them at all. Just don't get the acid on their lip. Okay, and then I'm going to neutralize the forehead, and we're done. The forehead is probably the least sensitive of all the areas, so. And then I do one more sort of go over with the neutralizing solution where I spray it on a gauze and then just go over it one more time. Okay? There you go. And then I'm going to spray it right onto a little gauze and then go over it one more time, because you're not going to see the bubbling now. How are you feeling?
Great.
Good. And like when you're kind of finishing up, it's good to give them a good mechanical abrasion too, because it helps. I think it helps take off extra dead cells. Might help lighten up more the pigmentation. And it gets all that comedonal debris that you extracted off their face. So they're not walking home with all the blocked keratinocyte junk. Okay. Let me just do one more spritz on your nose. Everybody give a hand to Paula. Thank you.
Thank you.
You did great.
Awesome.
All right.
Thank you.
Thank you. All right, Susan. Okay, thanks. So tell me, he's changing out the pillow. While he's doing that, you don't have to do that. Tell me, she had told me about those 2 brown spots she was concerned for. So is there anything on your face in particular that you're concerned for? So basically it's...
I've got one here, I've got one here, I've got some brown spots in
Okay.
A lot of sun.
A lot of sun. Okay. And then how about, do you get redness? Like, do you have any issue with blood vessels on the face? Or so I always kind of ask them what they're doing, what the peel is for, so that then you can tailor not only the ingredients, but you can tailor sort of the timing of different things that you do. So certainly for Susan, she doesn't have a lot of clogging. I don't have to do a lot of extraction, but you want to kind of see what you can do, because I think a lot of this fine lines, she has deeper rhytids that would benefit certainly from Botox and things like that. But even her fine rhytids here, we can focus more of the peel there and put more of it there, and maybe even have it on a little longer, so that it might take off some of the dead stratum corneum that's gone into these fine lines and made them look more prominent. Okay, so that'll make your complexion glow and your fine lines look better. So first, the pre-peel neutralizer. It's a 20% glycolic from Neostrata. Yeah, actually, in my office, the actual application of the product, I didn't do the whole face yet. The actual application of the product is done by either if I have a PA at the time, my PA, or right now I have a really good medical assistant who's actually applying them. Usually I'm in the room while they're doing the application, and then I do the extraction, or if there's any gauze abrasion, but they'll do the actual application, and then they'll stand there while the patient is. I sometimes have them rinse at the sink. I don't always do this neutralization. So, and certainly the neutralization part I think is the most important. So if you're doing it like this, then you probably should do the neutralization. You can have them apply it. Again, you need to supervise them a while so they don't get it in people's eyes and in their mouths and all those things. Okay, so cleaned off her face. Now we're going to do her little bit of petrolatum, corners of the mouth. See, I want to get this lip line on her, so I'm actually not going to put any petrolatum there. I'm going to just put it sort of where she doesn't have the lip lines. So in this situation, you have to be a little careful, but I think it'll work well, so you try and do it. And then again, right in the corners of the eyes so it doesn't go in. Are you sensitive in the corners of your nose? Okay. Thank you. Same thing, light brush, upward strokes. On Susan, I'm going to do 2 coats and apply a little bit, a good deal more product, because, like I said, I really kind of want to go a little deeper, and I want to really get into these fine lines, especially on her cheeks here, because I think this can do a lot of good for that. See, I did drip on her bib. That's why it's important for for their clothing to be covered. So I'm going to put a little smidgen on these little fine lines right in here, being careful not to go onto her vermilion border. Yeah, no, it's okay. Go ahead. Yeah, you can. And even into the deeper part of her commissure here. I'm not going into her lip, but I'm trying to get this line here. Again, always in upward strokes. So here you can see I'm focusing kind of really on her, what we call laugh lines. And then the outer parts of her crow's feet, because I think we'll do a lot of good there with the glycolic peel. Not as much on the nose, because she's not so clogged. Just do a little light coat on the nose. And you're going to use your clinical assessment. Everybody's a little different. That's why I think chemical peels are, there is a science to it, and it is interesting. And you are constantly learning. Okay, how much time?
1.5 minutes.
Has passed?
1 minute, 42 seconds.
Okay, so I'm going to actually do a brightening booster on her, just because she has some degree of overall sort of reticular photo damage. And so I'm just going to, you can hold that because I'm going to go back and do it. How are you feeling? Is it burning a lot?
Just a little bit. Feels like
Did I get it? She said she felt it dripping a little into the inner corner of her eye, so let's see if you can just, I'm going to actually put the booster all over her because, like I said, I think she could use a little bit of depigmentation everywhere. And with this, I like to use this to actually abrade a little too, as long as they're comfortable. Are you comfortable? Is it stinging worse?
It's definitely feeling definitely, but it's not bad.
Is it getting worse or is it getting less?
It's about the same.
Okay. Somebody was asking a question, I thought I heard? The boosters, Kojic Acid, arbutin, and 30% citric acid. And they have other ones too. The other one I have here is called a clarifying booster, which is an acne, more for acne and sort of extractions. And it has like 8% mandelic acid, I believe, and 10% citric, is that right? Yeah. And then what was the one other ingredient? I think resorcinol, is it?
20 mandelic, 10 citric.
Okay, 20 mandelic and 10 citric. Okay, and so the other thing, so the main two things I think I do with chemical peels more than other people is the extractions. I like to do myself if I think the patient really feels they get their money's worth if the doctor goes in there and presses on them a little bit and gets some junk out and shows them and stuff like that. And then I think also the gauze abrasion for the brown spots. And sometimes, then they're seeing how it's looking and they're like, oh, well, why don't you go ahead and spray that? And then I'll get, I'll do some, cosmetic liquid nitrogen with the peel so that the recovery is the same and, charge them maybe $50 to $80 extra for that. And so it can go on from there. How are you feeling? Yeah? Is it? She's turning a little red. You can see on her cheeks and her chin. How long do we have?
Almost 4.
Can I have the brush again? So I'm not going to go where she's red, but I'll just here that, like I said, her laugh lines. Turn and look all the way to the right for me. These are the little lines I was talking about that I'd love to see, that she goes home and in 2 weeks is like, whoa, these are better. So I'm going to paint one more coat on it before I do her neutralization. Turn all the way to the left so they can see those. Thank you, darling. Okay. Now I'm going to do her neutralization. Thanks. Again, how are you feeling?
Good.
Okay. Is it burning more?
No.
How about on the sides where I put more? Another thing I always learned when I was, started doing peels, and I think is really true, is that certain acids are very concentration dependent, meaning how much product you actually put on the person's face. The more coats you do, the deeper the effect, and the more of an effect you'll get, and the more recovery time they'll need. But some are very time dependent, and I think glycolic is the most time dependent of all of them. So you do need to watch your times on glycolic probably more than anything, and watch them, make sure they're not getting too red in any one area. You can certainly neutralize one area before the others. So for example, like let's say she's kind of redder here. Close your eyes for me. She's a little bit redder here, so we'll neutralize this first. And then those areas with those laugh lines that's really not turning red where I put the most product, I'm going to leave go a little bit longer. How's it feeling?
Okay.
So you can see the nice bubbling effect from the neutralization. Turn a little bit this way. Okay. Again, I didn't go below the brows or anything because in interest of the conference, but you certainly can. And that helps too. I'm going to do her nose now. Sorry, it sprayed in your eyes. Again, the bicarb is very safe, so it's okay that it's a spritz. The reason they like you to use it out of the bottle spritzing is because you can see the bubbling effect much better. And so if you're new to this, you know that you're neutralizing the peel much more accurately and completely. How you doing?
Good, thanks.
Good. That's soothing?
Mm-hmm.
Okay. So now remember I put a little bit extra on her lips, so I want to make sure and neutralize that really well because you don't want that to go into their mouth. Thanks. So you're going to go like this. Look at me. Like that. Perfect. So now this way I'll spray onto this and I'll get this off. And you can always do another spritz to make sure Because if you put a spritz on there and it's bubbling it all, that means you haven't gotten it all off. So it's a nice way to make sure you've gotten it all off. It's a good way to teach your assistants, et cetera. They think that they've gotten everything off. The patient's not sure, because they're not sure. They're just kind of tingling all over anyway, and so they don't know. Okay, so now I'm taking off the part that I did a lot on, her laugh lines, and then turn a little bit this way.
Are there any peels that are not safe during the breastfeeding?
I mean, certainly anything with retinol or retinoic acid, you know, anything that's vitamin A derived, I wouldn't do. You know, there's no absorption that we've seen, but it's certainly medical legally not a good thing to do, I would say. Anything that's sort of fruit derived, I think, is okay, you know. So all of these, citric acid, mandelic acid, they're all fruit derived, glycolic acid. Yes?
How often do you need to apply this?
How, I'm sorry. How often? Oh, okay. The question was how often can you apply these peels? You know, I know certainly practices where they do them every 2 weeks. It all depends on, you know, again, it's the real world, so what they can afford. And then, you know, if it's acne, you can certainly do it every 2 or 3 weeks. I do peels on myself every week. So, you know, I just do very light ones where I don't peel, and it just keeps my skin looking nice. So, and certainly on men, you know, a big part of my peel practice is men because they don't want to do cleanser. They don't want to do all this other stuff at home. So they definitely like to come in and get pampered and get a little peel and a little massage and go home. And they, you know, I have men coming in every 2 weeks just because they enjoy the treatment and then they don't have to use their cleanser and their acne products at home. So it all depends, but it's certainly safe to do it often. Yes? Well, TCA is a very strong acid. It will penetrate into the dermis. So definitely you can't do TCA on darker skin types. You know, I don't do much TCA in general. Most of my patients have very active social lives, and so I don't do a lot of TCA. So the question of what is best, definitely TCA goes deeper, but in terms of recovery and in terms of suitability for most patients' lives, and certainly here in South Florida, I think Glycolic is a much more user-friendly product. Yes? I have not seen studies about doing any peels in women who are I was going to say who are pregnant. You know, since these are cosmeceuticals, they don't have FDA pregnancy categories. I don't believe if a company were to have studies on pregnant women, it would be Neostrata, and I don't believe that you do. So yes, the answer is no, it has not been studied in pregnant women. However, the science of what they are would dictate that if it's a fruit-derived acid, they're certainly allowed to eat fruit in pregnancy, which is a much higher, they're getting much more citric acid from the orange they ate that morning than they are from the chemical peel you're doing right now. Okay, sweetie pie. You feeling good? Are you tingling anywhere? No? Okay, give a hand for Susan. Oh, the post cream, yes. Will you apply that for me? So this is a bionic post cream which Neostrata also makes, which is got a sunscreen on it. You know, generally my nurse puts on sunscreen on everybody after they leave. And this is a very soothing, nice one that kind of neutralizes the skin and takes away any excess. And people like the way it feels, and you can sell it out of your office and it gets them to buy it. Okay, I have 3 questions. I'm going to go 1, 2, 3 like that. So you're first. Yes, I do. The question was, do I do peels on the dorsal hands and the forearms? For those areas, you could definitely do stronger peels because the skin is thicker there. And again, it depends on the time of year and if they're going to be showing their hands and their forearms. Frequently for that, it's for SKs or lentigos, so I may combine that with a liquid nitrogen. But for that, you'd want to use kind of a stronger chemical peel. So maybe you could do the higher % glycolic and leave it on for a long time. You could do maybe a Jesner's, something that has a lot of different acids in it, that kind of thing. I still don't do TCA even on the body just because I feel like it's unpredictable. The question in the back? The question was, how long is the longest we leave peels on if the person's not having any burning? Or I have patients who've been getting peels monthly for 10 years and nothing will burn them. So, you know, I'll leave something on for 10, 15 minutes if I'm confident about the patient and their skin tolerance and I know their skin. So not really longer than 15 minutes. Third question?
What do you do, Manuela, when the patient says the peel didn't do anything?
Yes, the question was, how do you address the issue of when the patient, which very commonly happens, says, well, I got this peel from you, doctor, it didn't do anything, I didn't even peel. You have to pre-manage that, in my opinion. You need to decide, wait, first of all, you've decided clinically what peel to do on them, and you know in general what it's going to do for them. So you need to tell them, well, it's going to improve your brown spots maybe by 10 or 20%, 10% at best with one treatment, but over time it'll gradually improve things. And then I always tell everybody, you may not even peel. In fact, you might not even have changes that you can actually see on yourself from a day-to-day basis, but there are microscopic changes going on in your skin. And if you pre-manage them, you know, 90% of people will be okay with that. The 10% who still are not okay with that, you know, might be people who can go to another doctor. Yes? The Biore strips, I played around with them a long time when they first came out. I think that they're okay. They basically take out the debris in the open comedone, but they don't. Then they leave the open comedone there to collect debris again, and they're just as full as they were the day before. So if you're going to use it with the retinoid afterward, then maybe there's some use for it. But I find that I prefer to do the in-office extraction and then give them a Retin-A or Tazorac or something to take home. Okay, another question right here. No, that's you, yeah. I like this one actually. I think anything that doesn't soak up too much of the product into the brush so that you're not wasting a ton of product in the brush is good. So this one isn't really porous, and so it's allowing me to put a lot of product on their face without keeping a lot of it in. So, you know, obviously makeup brushes and things like that aren't good ideas because they soak up too much of the fluid. So something like this, what is this brush made of? It's like a plastic almost? Yeah, so I think it feels like plastic, and I think that's the least porous material, so that would be what I would recommend. The question was, what kind of brushes do we prefer to apply peels? I think you have to throw out the brush after you. The question was, can you use the brushes over and over again? And I said, I think the answer to that is you have to throw away the brush after each patient. Yeah, so then you have a closet a cabinet filled with brushes with people's names on it. I mean, these peel companies are very good about supplying us with brushes and stuff like that, and I don't have space in my office for keeping things like that. But you could, certainly, and keep it in a plastic bag or something like that. The question in the back? That's a very good question. The question was, what do you do about people who are on retinoids? And that also brings up another issue. I think retinoids, you know, definitely in people with Fitzpatrick 3 skin or greater, so darker skin types, they do need to stop their retinoid, even if it's a mild one. Like I think Epiduo does a great job with acne, but you know, it's still a retinoid, and it doesn't cause a lot of irritation, but they still need to stop their Epiduo probably 3 to 5 days before the peel. But of all of the retinoids, I think Epiduo can be stopped the closest to the peel. If they're on any form of Retin-A, that needs to be 5 to 7 days. I think Tazorac perhaps more than 7 days. In lighter skin types, we tell them to stop a day or two before. And then depending how they look after the peel, how red they are, how raw they are, is when I'll judge and tell them when to go back on their retinoid. It's anywhere from the next day to 3 days hence. And then one thing I wanted to say about retinoic acid is I use a compounded retinoic acid, which you can buy from any compounding pharmacy, and you can apply that as a second layer on almost any peel, and it makes it go a little deeper. So if it's looking like you're not getting much of anything and this person isn't going to be happy paying you $90 or whatever for this peel, put a little retinoic acid on it, and you'll be amazed at how that drives it deeper, or you can spot treat or whatever in a certain place, and it makes it better. Say the question again. I price my peels at $90 for the first area, meaning the face, if it's the first area, if it's just the chest, and then any additional area is $40 extra. on the same day. Yes? So if I'm doing, the question is if I'm doing liquid nitrogen at the same time for seborrheic keratoses or lentigos on the same day, I'll do the peel first, and then we'll take it off, and we'll neutralize it, and then I spray the liquid nitrogen. Because you don't want to do it on top of the acid, and you don't also want to abrade them after you've done liquid nitrogen on them. So that would be the last thing I do on a given session. Okay. If there are no more questions, we'll end this. Thank you so much for coming. Thank you to our patients.